Okay, chapter 15, alterations in blood flow. So in this chapter, we'll talk about the structure of our blood vessels, like our arteries. We'll discuss the role of the vascular endothelium and issues that can happen there. And then we'll discuss cardiovascular disease risk factors, and then conditions like atherosclerosis, and end with aneurysms. So here's a nice overview of the cardiovascular system. So just to review our anatomy, we have deoxygenated blood shown in blue, returning to the right side of the heart. It goes into the right atrium, through the tricuspid, into the right ventricle. This deoxygenated blood has to be reoxygenated, so the right ventricle will send it out through the pulmonary valve into the pulmonary artery to our lungs to pick up oxygen and expel CO2. That oxygenated blood will then return back to the heart through the pulmonary veins into the left side of the heart this time. First the left atrium, the bicuspid valve, and then into the left ventricle. The left ventricle will contract, generate a lot of pressure to pump the blood out the aortic valve into the aorta, and the aorta will then send it to the body, where our body's cells will then use the oxygen and create CO2, and then we have our deoxygenated blood again, and this cycle continues constantly. So the role of our circulatory system really is to deliver good things like nutrients and oxygen to our tissues, and then take away the waste, including carbon dioxide. The lymphatic system is listed here because the lymphatic system also extends throughout our body, and its role, or its interrelationship with the circulatory system, is that when we filter blood out of our capillaries, anything that we don't reabsorb back into our capillaries, the lymphatic vessels will pick up, and that will prevent us from suffering from edema. And then the lymphatic system will drain it back into the circulatory system. So here's a look at the structure of our arteries, and we also have our veins here. We have different layers of tissue, and starting from the layer that is closest to the lumen of our blood vessel, where it's going to touch our blood, we have our tunica intima layer. And that's easy to remember if you think about being intimate with the blood. So this is the innermost layer of endothelial cells, and again, this is the one that's in direct contact with blood. Then the middle layer is the tunica media layer, and it's made up of our smooth muscles. And then the last layer, the outermost layer, is our tunica adventitial layer, and it's made up of connective tissue. So let's take a closer look at our tunica adventitial layer. So that, tunica intima layer. So the one that's made up of the endothelium. So the endothelium is in every blood vessel, including our capillaries. So our capillaries just has a layer of endothelial cells because this is where all of our exchange takes place. So really, the endothelium is quite important because anything that is going to go into or out of our blood has to go through this layer. So it really is a gateway for exchange. So things like foods, gases like oxygen will pass out of the blood into our tissues, and then waste and carbon dioxide will pass out of the tissues into our blood through the vascular endothelium. That endothelial layer is also able to create compounds that will cause vasoconstriction or vasodilation, depending on what the situation calls for. The endothelium will also create growth factors. Remember growth factors we talked about in the cancer lecture? They stimulate growth. In this case, they can stimulate the growth of the smooth muscle in the media layer. It also forms that, again, smooth lining for blood to flow so that it's nice and smooth. There aren't any nicks or anything like that for clots to form. And then when clots do need to form because there is an injury, then it will promote clot formation by creating compounds necessary to stimulate that. So stimulate coagulation, which we just talked about. So what about cardiovascular disease? Well, that's quite important. It is the leading cause of death in both men and women in the United States. So let's discuss some risk factors of cardiovascular disease. Now, the good news is some of these risk factors are controllable. The bad news is some are not. So the uncontrollable risk factors include gender. So men have a higher risk than women. Age is another risk factor. So as you age, your risk increases, as well as having a family history of cardiovascular disease in your family. The controllable risk factors include things like smoking, being obese, having a sedentary lifestyle, that means someone who does not exercise, and then having untreated hypertension, so untreated high blood pressure. Now what I want to discuss are things that can alter blood flow. So structural changes to our blood vessels that might alter blood flow. And those include arteriosclerosis slash atherosclerosis, which we'll discuss in more detail, aneurysms, which is something we will also discuss at the end of this chapter. And then we also have valvular incompetence. So valvular incompetence is when your valves are essentially incompetent. They are unable to do what they're supposed to do. So valves, if you recall from your anatomy course, prevent backflow. And so we see valves in the heart. We also see valves in our veins. And in our veins especially, these valves help blood flow in one direction. When the valves get damaged and we have incompetence of these valves, then we are no longer able to prevent blood from flowing backwards, and so blood begins to pool, and that can cause our veins, our venous system, to really interrupt blood flow. The veins will start to kind of succumb to the added pressure of blood pooling there, and we really have poor circulation. And then we have arteriovenous fistulas, and these are just abnormal connections between the arteries and the veins. So now let's go back to that arteriosclerosis slash atherosclerosis and discuss that in more detail. So arteriosclerosis is any hardening and loss of elasticity of our arteries. So if you recall from your previous courses, your arteries they have a job, and their job is to be able to expand and fill up with blood. So when that left ventricle contracts and it pumps all that blood out of the left ventricle, it's pushing it into the arteries. And so your arteries will expand as all of this blood comes into it. And then another important thing that the arteries will do is it will recoil. And that recoiling motion kind of keeps the pressure going to keep blood flowing. When you have arteriosclerosis, your blood vessels are harder, so they don't expand to fill up with blood, and you lose that elasticity. And so this can really increase blood pressure and cause an issue. Now, atherosclerosis is just a type of arteriosclerosis, meaning the hardening and loss of elasticity in atherosclerosis results from the formation of fatty lesions in the intimal lining of the large and medium-sized arteries. So they include your aorta, the coronary arteries, the blood vessels that supply the brain. And you can really see in this figure a nice depiction of the areas where atherosclerosis happens in order of frequency. So abdominal aorta and iliac arteries has a high incidence of these clots forming. And then we have our coronary arteries, etc. So let's take a look at atherosclerosis in a nutshell. So in a nutshell, we have lipids that are circulating in our blood. They kind of get into our blood vessel wall. So they get into that vascular endothelium. Now they're not supposed to be there, so we have our white blood cells who respond, and they respond to try to clear away that lipid, and in the process of doing that, they create what's called a foam cell, and that's going to become the core of your atherosclerotic plaque. Now, these white blood cells, as well as the injured vascular endothelium, will then release growth factors to stimulate growth. Unfortunately, that growth really helps the plaque to grow, and that plaque can block your arteries, and that's how you have your plaque. Now, those lipids that are circulating in your blood circulate as lipoproteins because lipids don't dissolve in water, and so they're going to attach itself to proteins. And I'm sure you must have heard of high and low density lipoproteins. So the HDLs, or high density lipoprotein cholesterol, they are higher in density in protein, so they have more protein and less lipids. The LDLs, the low density lipoprotein cholesterols, are higher in lipids and lower in density in protein. So we get our lipids from our diet, and so we've ingested it, it's going through our intestine, and obviously bile helps us emulsify it so then we can absorb it. And when we absorb lipids, we absorb it as a chylomicron, and hopefully that sounds somewhat familiar from your physiology course. So as the chylomicron is circulating in our blood vessel, we'll deliver some of the fat to our fat cells, our adipose tissue, as well as to our skeletal muscles. And we end up with an IDL. IDL is just an intermediate density lipoprotein. The IDLs will then become our low density lipoproteins, so our bad cholesterol, our LDLs. And These can deliver the fat to the liver. So the LDLs will deliver the fat to the liver, and the liver is LDL receptor dependent. So they have receptors that can recognize, and the LDLs will bind to it, and the liver will take it up and remove it from the body. Some LDLs will get taken up by other tissues that are sometimes receptor dependent. Some of them don't need a receptor. So essentially, these are ways for our LDL levels in the blood to reduce. But some LDL, obviously, if you have a lot, will remain in the blood. And this is where scavenger cells can start to then come and interact and take them up and start to cause an issue, especially if, again, the lipids get into the lining of our blood vessel wall. Then our scavenger cells, our white blood cells, will encounter these fatty deposits in the lining of our blood vessels. They will try to destroy them, and they will do that by oxidizing them. And by oxidizing them, they actually end up injuring the endothelium. So the clots will form, and then the endothelium will release growth factors because it's injured, and that growth factor will actually stimulate the smooth muscle to actually grow over the fatty core. And that fatty core is made up of foam cells. And again, this is created when those white blood cells try to remove the fat by eating them, and they create that foam core of our plaque. So here's a nice image of our plaque that's been formed. So we have our core filled with the lipid-laden macrophage, and then you can see all the smooth muscle that has grown around it, and now the lumen of our blood vessel wall has this big old lump that it has to kind of deal with as it's trying to have blood rushing through it. Now, what about that HDL? So the HDL is our good cholesterol. So this is what we want a lot of in our body. And it's made by the liver, and things like exercise can promote more HDL production. But what they do, and the reason they're good, is because they can go out to our peripheral tissues and pick up lipids. And so if they can pick up lipids, these tissues can then pick up more LDLs when we bring it into our body. And so the HDLs will take it back to the liver so that then the lipid can be processed and removed. So here is a fictional scenario, but this man has several genetic defects in his lipoprotein receptors. So his liver lacks LDL receptors, and if you recall, the liver requires LDL receptors to pick up lipids. His muscles lack the receptors for the apoproteins on chylomicrons. And again, if you recall, when we absorb the lipids, we absorb it as chylomicrons, and then the chylomicrons will deliver some of the lipids to adipose tissue as well as muscle tissue. Here, he lacks the receptors for the muscles to take it up. His scavenger cells, his white blood cells, have extra LDL receptors. So why might he develop atherosclerosis? Well, first question is, will the liver take up LDL? And the answer is no, because his liver doesn't have the LDL receptors. What happens to blood LDL levels then? Well, if his liver doesn't take it up, then it's likely that his blood LDL levels will begin to rise. Will his muscles take up the LDL? And the answer is again no, because they lack the receptors. So what will scavenger cells do? They'll be able to find them much more easily because they have extra receptors. And so they're going to become the foam cells and really turn into plaques. And so he's basically most likely going to have lots of plaques in his body. Okay, next. There are different types of plaques that can form. We have a stable plaque and an unstable plaque. So let's go through the characteristics of each. So a stable plaque is stable, and the reason it's stable is because it has a thick fibrous cap. So it has this nice thick cap around it, so that smooth muscle layer is nice and thick. So what happens is it tends to not balloon and grow really big to block the entire blood vessel. As a result, it typically just partially blocks the blood vessel. Also, because it only partially blocks the blood vessel, it doesn't tend to form a complete clot. And because it's stable, that nice thick cap around it is more stable, it doesn't tend to break off to form an emboli. So it's stable, it stays where it is. An unstable plaque is unstable. And the reason it's unstable is because instead of having a thick fibrous cap, it has a thin fibrous cap. So it can really balloon and grow. And so it may completely block the artery. and cause a clot to form, so blood won't flow. In addition, that clot can break off and form an emboli and cause a blockage somewhere else. So, which would you think is more dangerous? So either plaque we really don't want, but something that can break off or completely block blood flow is obviously going to be more dangerous, or unstable plaques. So in another scenario, we have a woman who complains of pain in her left leg. What could have caused each of these symptoms? So her foot is cool and pale. So what would make her foot cool and pale? Low arterial blood flow. So if there's no blood going to a leg, it's not going to look like there's blood going there. So it'll be pale and it'll be cool. But when she's sitting down, it is red and warm. So her leg would be red and warm for the opposite reason. There's too much blood there. So she has pooling of blood there. So she has pretty much poor circulation. And so gravity, when she's sitting down, just kind of holds on to that blood. And then it says the pain occurs when she's walking to church on Sundays. So why does it hurt when she's in motion and walking? Because we've already established she has poor circulation, she probably has a lack of oxygen, and that's causing pain in these muscles that she is exercising when she's walking. And then her skin on that leg is shinier than on the other leg, the right leg. And that's because not only are her muscles not getting oxygen, but neither is her skin, and that's causing atrophy in the skin. So let's end with an aneurysm. So an aneurysm is a localized blood-filled dilation of arterial vessels. So this is not the same as a vasodilation. So our blood vessels vasodilate to try to bring more blood to an area. In this case, what happens is we have blood vessel walls that have weakened. And so when we have all of this blood and all of this blood pressure that's being exerted on our blood vessel wall, they can eventually weaken. And so when they weaken, they're not going to be able to stand up to that pressure, and then they just kind of end up stretching and not being able to recoil and go back. And so we just have this big old ballooning, this big dilation. And so blood doesn't flow well here. So it's not going to increase blood flow. It's actually going to kind of impede, and blood is going to kind of pool here. So it really interrupts normal blood flow. Plus, the area in this, the blood vessel wall in this area is weak, so there's going to be increased risk of rupture and hemorrhage. There's also an increased risk of clot formation. Now, it's frequently found in the cerebral circulation as well as the thoracic and abdominal aorta. And if you do have a dissecting aortic aneurysm, it is a medical emergency and has to be treated right away, because the aorta is really where we have the greatest pressure, because that's what's coming right off of that left ventricle. And so blood will really just gush out. Now, we can classify aneurysms several ways, and I just want to talk about two major ways, and those are true and false aneurysms. So in a true aneurysm, we're really saying that all three layers of your artery wall are involved. So if you look over here, you see that the entire artery wall has dilated. And here we're having one side, here both sides, but this is a true aneurysm. We have this dilation of your blood vessel wall. Now, atherosclerosis has been shown to be a cause of this, that it can actually lead to this. And if you think about it, if you have atherosclerotic plaque, our blood vessel wall we've already compromised and weakened, and so again, it can increase the likelihood of an aneurysm occurring. In a false aneurysm, from the outside, the blood vessel will actually look the same, but if we look at the inside, what's happening is blood is actually going in between layers of our blood vessel wall, so the inside lumen looks different. You see how here it's straight, here we have this dilation. On the outside, it looks the same. Okay, so this is known as a false aneurysm. So we'll end with this quick flow chart about lipids. So we have lipids being absorbed from the GI tract. And if you recall, when we absorb them, we have them packaged into these little chylomicrons. So this is part of just normal absorption of fats. Now, some of those chylomicrons, where do they go? Well, some are delivered to fat, adipose tissue. Some go to our muscles, right? Our muscles can take it up. But most of the remaining ones will go to our liver. Now, what types of lipids do we have? Well, we have some of the remaining lipids in the blood will form the LDLs. We have VLDL. That just stands for very low density lipoprotein. I wouldn't worry too much about that one. But the ones that go to the liver, remember the liver can release HDLs. Now, let's go here. Some of the remaining lipids form LDLs in the blood. Well, what happens to them? They can attach to LDL receptors on other cells and be taken up. But if we have some sort of damage, then we have our scavenger cells, our monocytes and macrophages can eat them up, creating that foam cell, which is going to be the core of our atherosclerotic plaque. Now, if we go back over here, our HDLs, why are they so good? Because they go out and they pick up lipids and cholesterol from our peripheral tissues. And they will carry it back to the liver so that the liver can then process and remove it. And by doing that, it's going to inhibit cellular uptake of LDLs because we're removing the LDLs from the body. And that is it for this chapter.